back to the apex. So to get full neurovascular control with anesthesia, we will introduce the remaining 5 cc's at the apex. So at this point, delivering more anesthesia under the seminal vesicle to ensure a optimal blockade for the resumed BPH procedure. So clearly, the delivery and the anatomic precision of the urological and vascular structures are unprecedented. So again, entering the contralateral seminal vesicle and piercing through the seminal vesicle and doing, again,
1.5 centimeters up from the anal verge in the midline is marked, and 1.5 centimeters to the right and left of this point laterally. Approximately 1 ml of local anesthesia is injected using the orange syringe to numb the skin. Using the ultrasound probe, the sampled cam probe device with an attached 10 ml local anesthetic syringe is then inserted at the marked points. If there is any resistance or the skin feels particularly resilient, a small stab incision using a blade can be used on the pre-anesthetized skin. As the cam probe is inserted under direct vision, structures can be visualized, including the subcutaneous fat, pelvic floor musculature, and the apex of the prostate. Patient feedback is also helpful to assess if any further local anesthesia needs to be introduced in specific areas. Approximately 5 to 6 ml of local anesthesia is required per side of insertion and to keep the procedure comfortable. There is no requirement for any pudendal nerve blocks, wide infiltration, or regional anesthesia. Once the cannula is placed just adjacent to the apex of the prostate, some further local anesthesia is inserted at the apical junction. Once deployed, the syringe and inner delivery needle is removed, leaving the cannulation probe ready for prostate biopsies. A standard biopsy needle, 18 gauge, is inserted through the cannulation device with no need for any extra insertion points. Under ultrasound guidance, the cannula is then directed to different areas of the prostate for samples to be taken. At all times, visualizing the end of the needle and the direction of travel through manipulation of both the linear ultrasound probe and the biopsy cannula. The free hand movement that the cam probe affords means that apical areas of the prostate as well as basal and lateral areas are easily accessible. However, if the positioning of the cannula needs to be altered, this can be easily achieved by reinserting the local anesthetic needle back in and reinserting the cannula, and if necessary deploying a little more local anesthesia. In our pilot trials, we have found that separate skin punctures are almost never required because of the malleability of the perineal skin and subcutaneous.
The process begins by inserting a rectal probe. The probe will help the medical professional navigate the course of the treatment. During the next step of this process, 2 very thin needles are inserted into the prostate via transperineal access into each of the lobes. This approach avoids damaging urethra tissues and minimizes complications. Each of the needles is equipped with optical fiber. Each fiber emits low-power laser energy, typically 3 watts, for a few minutes. The portion of thermally treated tissue is naturally reabsorbed by the gland in the following weeks, resulting in a reduction in the prostate volume and the resolution of symptoms.
Case of BPH, benign prostatic hyperplasia. It came with obstruction, so we have done ultrasound. There is a 80 cc, moderate hyperplasia. So now we are planning a new method, minimally invasive, supra-minimally invasive, transrectal ultrasound guided, transperineal microwave ablation of adenoma of prostate. Okay, this is a transrectal ultrasound guided and transperineal microwave ablation of prostate. The new concept, and we'll show you. There is a prostate, how it's moderately enlarged. This is a right lobe, left lobe, and the median lobe also enlarged. This is a urethra, this is a Foley's. So we have put a 3-way Foley's to continuous irrigation shield saline, so it will protect the urethra. So our target to reach this adenoma and this adenoma. So we have in this direction, so this direction, this is a urethra. This is a urethra direction. So longitudinal, right? So we want to target 2 lobes adenoma, okay? But the target, it's a limitation. See, from bladder neck we have to away from 1.5 centimeter, and the urethra for 1 centimeter, from capsule 1 centimeter. You have to avoid ablation. From bladder is 1.5 centimeter, urethra 1 centimeter, and this from the prostatic capsule 1 centimeter. So we have to ablate this. So as in microwave, so because of we have to give three firing shots here. So 1, 2, 3. So we plan for 30 watts and 10 second one lobe. 30 watts, 10 second, 3 shots for this lobe, right? Right there. The transperineal marking is you can have the 1.5 centimeter, then 1.5 centimeter. So this is for the right side, left side. This is for right side. This is for left side, 1.5 centimeter. So this is a marking, the entry point. So we'll the 5 mm active tip. So from this area, transperineal approach. Okay. Yes. The pelvic floor. Okay. Okay, you got it right. Sixteen gauge antenna, 15 centimeter, 3 mm is active tip. You can see the machine 10 seconds, 3 shots for each lobe. Gauge antenna, we are entering transperineally above 1.5 and width is 1.5. So I am entering it direct to the prostate of the left lobe. Okay. So right. So after entering the prostate, you can see there, and we'll give a here firing. Right. So this is a minimal invasive, supra-minimally invasive for transrectal ultrasound, transperineal microwave for ablation of adenoma of the prostate. So if you compare like a tuna, TUMT or laser, or you can have a mechanical management or thermal management, hydro steaming management, resume, aqua beam. So there are even stents also, like a lift procedure. All these have a less limitation and more like it's not a long standing, it's not so specific results. So this is a novel technique, a best technique in future with the prostate microwave ablation transperineally. So we have the team, MDT, multidisciplinary team. MDT, multidisciplinary team, like you have urology, radiology, and the microwave surgeon. We are doing team spirit for minimal invasive, the management of mild to moderate BPH with managing microwave, ultrasound guided. It's a daycare procedure, minimal bleeding, minimal complication, and the main advantage, sparing ejaculation. There is no retrograde ejaculation. That is the main advantage. And main, you have a quality life, IPSS score, everything will be, it's a good specific efficacy is there. So we recommend for moderate prostate, mild to moderate prostate, transrectal with the transperineal microwave.
E la conservazione del tessuto sano e della funzione degli organi.